Hello everyone, I'm Dr. Sakshi. I'm a pediatric cardiology resident, and this is the first video in the series to follow where I intend to discuss certain common cardiovascular ailments pertaining to pediatric population. In this particular video, I'll be discussing about Kawasaki's disease. By the end of this video, you should be well aware about certain historical snippets from Dr. Kawasaki's life and why he referred to this disease as a GOG entity. You will also know about what all possible etiologies do we think cause Kawasaki disease and how variedly it presents and what diagnostic criteria we follow as of now. Any discussion about this disease is incomplete without knowing the life of Dr. Kawasaki. This gentleman, as you can see, is Dr. Tomisaku Kawasaki. He was born in the year 1925 and he very recently passed away in the year 2020 at the age of 95. To begin with, he did not per se want to be a physician, but his mother wanted him to be a physician, and he was very fond of kids, so he became a pediatrician. And this is the hospital where he received his pediatrics training. It was based in Tokyo. This was also the hospital where he eventually practiced as a consultant, and this is again also the hospital where he first found a very peculiar case in the year 1961 when he was taking rounds. He came across a 4-year-old kid who presented with prolonged fever. And along with this prolonged fever, which was around 2 weeks of duration, he had certain features which we now refer to as GRAM, which is conjunctivitis, rash, lymphadenopathy, and mucosal involvement. He found this very peculiar. He went back to literature, went on to reading what all conditions have all of these entities, and he found no reference at all of any syndromic presentation which had these presentations. And this particular patient of his also had Coombs positive hemolytic anemia. So he thought maybe it is some autoimmune condition, but he never exactly understood what was happening with this kid. Anyway, this kid improved eventually, and because he never understood what the kid had, he noted his findings under the title GOG, which is God only knows what the kid had. And he went on ahead. The very next year, he found another kid, 1.5-year-old boy, who had an uncanny resemblance with the presentation in terms of presentation to the previous patient, and he was wonderstruck what this disease entity is. He went back to literature, went on reading, researching. He still could not find any entity which was described in literature, and again he noted all these findings under the title GOG. Then every passing year he would come across 5 to 10 similar cases and he would not understand what these were. He would just go and keep on writing the findings under GOG, and then he collected all his case series and went on to presenting his case series to Japanese Pediatric Association. The way we have IAP or AAP, he presented his case series to JPA. And he was of the notion that this is a new disease entity which needs to be explored and researched upon. And those people at JPA, they weren't convinced with his proposal. They were like, nah, this is not a new disease. This is maybe an atypical presentation of scarlet, and or it could maybe be a Still's disease or a different presentation of Soja. They upfront refuted the proposal that this was a new disease entity. Anyway, Dr. Kawasaki, he was very firm. He knew this was something new and needed to be explored more. And he went on to collecting his cases. And by the year 1967, he had collected a data of 50 such cases. He went on to write and describe all his data in a 44-paged article. He wrote a very elaborate 44-paged paper, which has been described till date as one of the most beautiful examples of descriptive clinical writing. He had included hand drawn illustrations of how the rash was distributed. It was present in perianal region, it went on to extending into torso and to the extremities. And he also included colored photographs of his patients, and this article was basically published in the Japanese Journal of Allergy. We now know that Kawasaki disease per se has no association with allergy, but back then nobody else would let him publish his article in their journal. So he published it in Japanese Journal of Allergy in the year 1967. After this was published, other pediatricians they read about it and they saw similar presentations in their practice, and eventually it became a well known entity all over Japan, and everyone started calling it Kawasaki disease. Dr. Kawasaki himself, per se, he was very humble. He wouldn't call it Kawasaki disease, he used to refer to it as mucocutaneous lymph node disease. Anyhow, that particular time, they had this notion that it was a benign entity, self limiting entity, which did not have any further future consequences. But things changed in the year 1970. There was a nationwide survey conducted across Japan, which included all the kids who had had Kawasaki disease, and they found that these kids had a very high, significantly high incidence of sudden cardiac death, which was attributed to acute coronary events. And on autopsy, they found that these kids had coronary aneurysms. So, this is how the existence of coronary aneurysms began to be associated with Kawasaki disease. This was in the year 1970, and this was the first article which was published in Japanese language. Then it was translated in English in the year 2002, and somewhere in between, I guess in 1992, um, we found first references of Kawasaki disease in our Nelson's textbook of pediatrics. Now, coming to the definition of Kawasaki, this is from Moss and Adams. It defines Kawasaki as an acute and self limiting vasculitis manifested by high fever and all the cramp findings. I want you to focus on the coronary arterial wall involvement and occasional other medium sized systemic arterial involvement. What we need to know is how frequently coronary arteries are involved if we do not intervene at all and follow the natural course of disease versus when we give IVIG. So it has been seen that 1 in every 4 child will develop some form of coronary arteritis if you do not intervene, and that sums up to 20 to 25% of kids. And if you give IVIG, the number turns to be 1 in 20, that is less than 5% will still develop coronary arteritis. But there's a significant reduction, as you can see. What is the etiology? Per se, we are not very sure of what the exact etiology is, but what is the most agreed upon paradigm is that there is either an infectious agent or there is an environmental trigger which basically triggers a detrimental immune response in a genetically susceptible organism. I know it seems like a very blanket statement, but there has been ongoing research which has found that there are certain intracytoplasmic inclusion bodies, supposedly viral in nature, but we don't know what exact virus that is, against which the body forms the detrimental immune response in the form of antibodies. And there are certain genetic polymorphisms which make the child more susceptible to having Kawasaki or have coronary involvement in Kawasaki or be IVIG resistant. Now let's learn about each of the cramp findings in detail. Very first finding, as we see, is rash. Now this rash is a polymorphous rash. It can be of any type, macular, papular, but it is never ever vesicular or bullous in nature. And this rash might be evanescent or transient rash, and therefore you need to ask the mom a leading question. Otherwise, she might forget to mention, and you'll miss out on this very finding. This rash usually begins in a perianal region, so a diaper rash, which extends onto torso and extremities. Along with prolonged fever, you should think of Kawasaki disease. Then we have bulbar conjunctivitis, which is usually a bilateral bulbar conjunctivitis, sparing perilimbal region by 1 to 2 millimeters, and it is always non exudative in nature. Then there is erythema of oral cavity and lips. So here you can see red chapped lips with erythematous tongue, or there might be a classical strawberry tongue. Then we have swollen hands and feet, which basically happens early on in the course of disease, which is less than 7 days of duration. You'll have swollen hands and feet, and the mother will know more will for always remember to mention this because the child will be refusing to move hands or bear weight on feet because of involvement of proximal interphalangeal joint, which is swollen and erythematous in the first 7 days of disease, and this is followed by periungual desquamation, which is again almost always pathognomic of the disease, and it happens beyond 10 days usually. After this, we have unilateral cervical lymphadenopathy, again non-purulent, and it is significant, which is more than 1.5 centimeters. Then there's coronary arterial involvement. Now, this coronary arterial involvement is patchy, unlike atherosclerosis. which is always diffuse in nature. So the vessel wall is not diffusely involved, and instead there is a patchy involvement of arteritis that leads on to becoming aneurysm when it dilates after weakening. And then sometimes it might not be coronary involvement, it might be other vessels which are involved, which can lead to dactylitis and sometimes even lead to Raynaud's phenomenon. Sometimes there will be a renal vessel vasculitis. At other times, there will be BCG scar reactivation. And this has been found in almost 50% of kids, especially in a country like India, where there is a rampant use of BCG vaccine. In our hospital, we had this kid with typical strawberry tongue who was diagnosed with Kawasaki disease. Again, you can see male child, more frequent in males, and less than 5 years of age. Then this was another child who was having all the typical findings of Kawasaki in bilateral non-purulent conjunctivitis, perilimbal region. But as you can see, this child was more than 5 years of age, so we investigated more, and this child was found to be having MIS-C. It was COVID era, and he came COVID antibodies positive. There is more to the clinical findings, but let's first discuss about the diagnostic criteria. This diagnostic criteria, which we see, was first put forth in the journal Circulation in 2017, and the diagnosis of classic Kawasaki has remained more or less the same since ever. I remember it as 5 plus 4 or 4 plus 5, which is 5 days of fever with 4 out of 5 gram findings, or 4 days of fever with 5 out of 5 gram findings. But there is nothing which is religious about these figures, and people who are very much experienced, they can diagnose Kawasaki even at day 3 of fever. So, what's more important than this classic Kawasaki is an entity called as incomplete Kawasaki disease. And the kids who have incomplete criteria of Kawasaki are in fact more prone to developing coronary artery aneurysms. Who are these kids? Basically, any infant who is having a fever of more than equal to 7 days of duration with an unexplained cause, you should think about incomplete Kawasaki. This is the first case scenario. And secondly, any child who is having more than equal to 5 days of fever, again unexplained fever, with 2 or 3 clinically compatible criteria of Kawasaki, you should think about incomplete Kawasaki disease. And for all of these kids, you should do an ESR and CRP. If the ESR and CRP is positive, which is more than equal to 40 and more than equal to 3, you follow this child with an echocardiogram. If there is involvement of coronaries, you label as incomplete Kawasaki disease. If echo is negative, you follow these kids with certain lab values, and if 3 out of 6 of these lab values are positive, again you diagnose as incomplete Kawasaki and treat accordingly according to the Kawasaki management protocol. What are these 6 findings? We can have anemia for age. We can have thrombocytosis, which happens after 7 days of disease, hypoalbuminemia, elevated ALT, leukocytosis, or sterile pyuria. If 3 out of 6 findings are positive, you label as incomplete Kawasaki. Now, what if ESR and CRP are negative? If that happens and you're still doubtful because the fever is still persistent and the cause is still not known, you need to follow up this child. If on follow up you find there is periangual peeling, you do an echo. If there is positive coronary involvement, you diagnose and treat as incomplete Kawasaki. And if any point during the follow up, if any point the child develops positive clinically correlatable criteria or positive labs according to these 3 out of 6, again you diagnose as incomplete Kawasaki and treat accordingly. And therefore, you know that Kawasaki is not a simple CRAM criteria. It can present as an incomplete disease wherein less than 4 findings are present. It could be an atypical disease wherein organs other than heart are involved. There can be pulmonary infiltrates, so it might look like pneumonia, wherein you find a pulmonary infiltrate. It could present as aseptic meningitis or pancreatitis or gallbladder hydrops. So any finding which is not fitting into the typical finding, and it could be a atypical Kawasaki, a child might just present with a fever of unknown origin. And usually for these kids having fever of unknown origin, we think about infectious endocarditis, and for that we'll be doing echo. But instead of finding any vegetation, we'd rather find coronary aneurysms or some degree of arteritis of coronary vessels. And very recently, KD has been associated with myocarditis. And sometimes in less than 5% of kids, Kawasaki disease presents as shock. And you might be thinking about a sepsis causing shock or MIS-C causing shock or a toxic shock syndrome, but in fact, the disease had always been Kawasaki. And kids with Kawasaki shock syndrome are more prone to develop coronary artery aneurysms, and they'll usually be having very, very severe GI findings or GI presentation to begin with. And that's all for today's lecture. In the next lecture, we'll discuss about coronary aneurysms, which all vessels are most frequently involved, who all is more susceptible to developing these aneurysms, how we manage a child with Kawasaki acutely and chronically, how do we follow them up, and what all exercise recommendations have been put forth for these children who've been once labeled as having Kawasaki disease.